Thank you for the introduction. It was very nice. I want to thank the organizers for having the opportunity to present a patient from our clinic. So our patient is a 49-year-old man with ankylosing spondylitis. He was presented with gradual F4 dyspnea that developed over several months, a typical presentation. He was admitted to the cardiac care unit on June 2013 with acute congestive heart failure. On his echocardiogram, he had a very typical amyloid heart with a mild RV dysfunction, also a diastolic dysfunction, with a significant biventricular hypertrophy. We can see that his IVS was 17 millimeters. He had a myocardial sparkling, thickened heart valves, and small pericardial effusion that are all typical of amyloidosis. He was our first patient to go cardiac MRI in our hospital, and I want to show some photos from his MRI. So this is a general view of his heart. You see the 4 chambers. You can see the thickened myocard, both on the left ventricular and right ventricular. You can also note that on the atria there is also thickness in the of the walls. This is the initial phase after we administer gadolinium. You can see that the gadolinium, the white, is filling the heart chambers, and you can see the muscle that is thick but is not enhanced. This is usually what happens, but when we look on the late gadolinium phase, what actually happens on, this is the, let's focus on the left ventricular chamber, is that usually the myocard should not enhance because it's the myocard and it doesn't take up the gadolinium. But if there's something infiltrates the heart, then gadolinium will enter. You see it's whitish. This patient had a cardiac biopsy, and you can see what infiltrates his heart. On the left side, we can see the myocytes, and surrounded by some fibrillar deposition, and it's stained for color red. And also on the right side, you can see the light chain lambda that is also positive in the interstitial of the myocard. Not surprisingly, on his protein electrophoresis and immunofixation, he had the light chain, lambda light chain monoclonal band. We also performed the free light chain assay that showed an excess of lambda light chain at 48, with the difference between the lambda to the capital 46, which means it's a monoclonal, and there is actually reflects the tumor burden. On his aspirate and biopsy, we have seen 20% of lambda-restricted plasma cells, which is a bit higher. Usually, amyloid patients have around 7%, so it actually puts him in the myeloma category. We can also note an amyloid deposition in his bone marrow. Now, you've heard from Professor Pollack about the other organs and tissues involvement in amyloidosis. So our patient had also a kidney involvement with nephrotic range albuminuria. He had 7.6 grams per day, which is quite high. And the creatinine was a bit elevated at 1.35. We have not seen any other organ or tissue involvement. So our patient has the diagnosis of lambda light chain myeloma with cardiac and renal amyloidosis. Now, the heart is the heart of the issue. I mean, this is what actually determines the prognosis of our patient. So we need to do a very thorough evaluation of his cardiac status. So he was a near 2. His blood pressure was very low at 80/60. And you have both elevations of the cardiac biomarkers, both the troponin and the proBNP was elevated 6-7 times of the upper normal limit. Just for conversion, we use the proBNP. Most facilities in the world use the anti-proBNP, so it's roughly 1,300 anti-proBNP. Now, before we start treatment, we need to look at the outcome of this patient, and we have two prognosis systems that were built on AL amyloidosis. One is from the Mayo Clinic. They use 3 factors. 2 of them are the cardiac biomarkers, and one is the tumor burden, the differences of the FLC. Our patient have both, all the third of these risk factors, which puts him in stage 4 with a projected survival of only 5 months. Another risk system comes from Europe, and we have 2 risk factors in this system: the anti-proBNP at a high cutoff and the systolic blood pressure below 100. This patient has only one of them, puts him in intermediate risk, but also a projected median survival of only 6 months, which is very comparable. So with this dismal outlook, he immediately began treatment protocol. We usually give the VCD if it's tolerated by the patient, that composed of bortezomib, the Velcade, titoxan, and dexamethasone. Our patient received 6 cycles of this combination that spanned over roughly half a year, and continues with bortezomib and dexamethasone maintenance on a regular basis. Now, this is his response, which was quite remarkable. This is the difference in the FLC. You can see that it was a rapid response. I mean, in 25 days, the difference was eliminated totally, and maintained itself throughout the days of his follow-up, reaching 600 days with a normal DFLC. So our patient actually is in complete response, also confirmed by his bone marrow biopsy that shows no evidence of clonal plasma cells. Regarding his cardiac response, you see it's more gradual and still incomplete. The time span here is months. So we still have elevations of both the proBNP and the troponin, but they are all on the way down. Clinically, we can use the 6-minute walk test, and for his 49 years old, so the normal value for his guy like him is around 6 meters in the 6-minute walk. On his presentation, a few days after he started treatment, he could walk 360 meters. 3 months later, he almost doubles it and maintained his good walk distance throughout his follow-up. We also performed the cardiac MRI almost a year after the initial diagnosis. You can see that the myocardium looks like thick, and the ejection fraction actually increased from 53 to 67, which correlates with his clinical improvement. And to mention, this was the only modality that shows the improvement in his ejection fraction. The echocardiogram could not demonstrate this significant improvement. Now, our patient underwent autologous stem cell collection for future transplant. Now, this patient presents to us a clinical question. I mean, he's now in a good condition. He's improving in his heart. And the question is, should we refer him for this dangerous transplantation, or maybe defer it? And I want to bring only 2 slides about it. First, we know that patients with significant morbidities, mainly the heart, but not only the heart, have a very high transplant-related mortality. If it has elevated troponin or the proBNP or low systolic blood pressure. So our patient fits in his presentation. This is why we didn't refer him for the transplantation. On the other hand, we know that patients with AL amyloidosis do survive better than the myeloma patients when they are transplanted. I mean, the transplantation is a very crucial treatment if we want to prolong their survival. For example, the median overall survival of AL amyloidosis includes hearts and not the heart, is after transplant is over 100 months compared with only 60 months in symptomatic myeloma patients. But also know that the first year, the AL amyloidosis do less better. They die often, more than the myeloma patients. So it's truly a dangerous or risky procedure that need to be considered very thoroughly. This is my acknowledgments, and I open the for discussion about the case or other things that relates to cardiac amyloidosis. Thank you.